Dr. Iland, thank you very, very much for your fantastic presentation. It was absolutely edifying for me, and I hope it was for most of our audience today. Now, give me one second.
Good afternoon. My name is Nicolas Correa. I am a clinical coordinator here in Advanced Scientific Group. So at this moment, I'm going to read some questions left into a chat.
Now, I would like to go back to today's program
Sorry.
and go through a few questions that came out during the presentation.
Sure. I think Nicholas wants to talk too.
Yeah, yeah. Thanks, Don Mauricio.
The first question is, please, Nicolas, go ahead.
Yeah. To make a continue to read this question. Sorry, Dr. Island. The first question was from the doctor David Garay, and he asked, in a high-risk patient with hyperleukocytosis, adding an anthracycline-based regimen to ATRA should be the standard treatment for the induction phase, or what will be?
In Australia, the standard treatment for high-risk patient is atra, arsenic, and idarubicin. So atra for 36 days, 4 doses of idarubicin, and arsenic trioxide. We start on day 9. The Children's Oncology Group, which modeled their protocol on ours, they start on day 1. And the MD Anderson also start on day 1. So you could certainly start on day 1. We opted, when we first started this protocol, not to overlap idarubicin with arsenic because they both have cardiac issues, and we weren't sure whether there would be a problem combining the two potentially cardiotoxic drugs. It turns out that that's not anything that you need to worry about based on the Children's Oncology Group study. But yes, in this country, all 3 drugs are given in induction for high-risk patients. But no more idarubicin after induction.
Okay, okay. And as we have and a second question, but from us, because it's not common to find some children patients with APL, but exists the possibility. So in this population, in this specific population, have you had some experience with ATO or anthracyclina regimens?
As I said, I don't treat the pediatric population, but they were included in the APML4 study, but there were only 4 patients under the age of 18 who were included on the APML4. So I can't really comment, but the Children's Oncology Group is a big study, over 100 patients, I think, and they reported as I showed, very extremely good outcomes with the latest protocol, which is very similar to our induction and the Lococo consolidation. And the doses they use are the same. They use the same arsenic dose, 0.15 milligrams per kilogram per day. They use the same idarubicin dose. The only difference is they use half-dose atra because the problem of benign intracranial hypertension is perhaps more problematic in children due to atra than in adults. And so typically the children dose is lower. Although in Australia, when we used the APML4 protocol, the children enrolled in our study were given full dose, 45 milligrams per square meter of ATRA. So I'm not sure how common the headache problem really is, but most certainly the US recommends half dose for pediatric patients of ATRA. But the other drugs are given at the same dose.
Okay, thank you so much, Dr. Island. Well, here in the chat, we have reached some questions, another questions. For example, Juan Camilo Villada, the doctor Juan Camilo, um, has made two questions. The first one was about the omission of the maintenance phase in the patients with a normal or moderate risk that use ATO in both files. Yeah. And the second question was about the safety of ATO therapy for a long time.
For for uh, for standard risk patients, I mean the way APML4 was designed was atra arsenic idarubicin induction, atra arsenic consolidation for 2 cycles, and then maintenance. My own preference now, and the way we did the APML5 study, is to give a standard risk consolidation. In other words, 4 cycles of atra arsenic and no maintenance. And the only difference for high risk and standard risk is the induction, where you use idarubicin, you add idarubicin for high risk and just atra arsenic for standard risk. But then in consolidation, my personal preference is to give 4 cycles of atra arsenic and no maintenance, whether or not they have standard risk disease or high risk disease. And the other question about long term, was it long term atra or long term arsenic?
Sorry, doctor, can you speak again the question?
Was that long term atra? Was the question, or long term
Yeah,
arsenic?
it's about the safety in ATO regimen in a long time because of the cardiotoxicity is common in this regimen.
The cardiac toxicity is just the QT prolongation, and most patients don't get QT prolongation. If you see QT prolongation, you can't just keep giving arsenic. You have to either reduce the dose or interrupt treatment for a few days until the QTC interval corrects, and then resume. And most of the time you can do that. There's very few patients in my experience who can't finish the course of arsenic that's required because of QTC prolongation. Um, in terms of long-term arsenic toxicity, there's a study that was published from Chinese data looking at 12-year follow-up in patients who had been treated with arsenic-based protocols. And the only long-term toxicity that was evident compared to patients who hadn't received arsenic was grade 1 liver function abnormalities and hepatic steatosis, fatty liver, was seen more commonly in patients who'd had arsenic therapy as long ago as 12 years ago. So I think the safety of arsenic is pretty well established when given as as part of APL treatment. There was no increase in second malignancies. There was no long-term cardiac or renal toxicity. The only thing was a mild liver toxicity, and there are a small number of patients who have neuropathy and can't complete treatment because of neuropathy. But if you complete the treatment without neuropathy, you don't develop neuropathy later on.
Okay, thank you so much, Dr. Island. Well, this is the last question from Diana Margarita, the Dr. Diana Margarita. So she asked us about the count of neutrophils. She said that in the protocol ATO and ATRA to allow risk patients starts with 200 neutrophils, but at the day 10, the count of neutrophils is 50 50,000 in blood. So the ask is how many time we have to expect to evaluate the efficacy of the treatment.
Sorry, I missed something there. How many times what?
How many time we have to expect, or how many time have to pass to evaluate an efficacy of response of the treatment related with the count of neutrophils.
The neutrophil count will usually goes up with atra-arsenic, and the white cell count can go as high as 50. I've seen a white cell count of 100 in a patient treated with just atra and arsenic. Um, you the plan the strategy is to not stop the atra and arsenic, but to give hydroxyurea to control that white cell count. And there are the APL0406 study had a protocol where I think the dose of hydroxyurea was 500 milligrams 4 times a day once the white cell count rose above 10, and when it rose above 50, to go up to 1,000 milligrams 4 times a day, and uh, that is usually sufficient to control the white cell count. And most studies of standard risk APL, in which you see that rising white cell count, um, have virtually 100% complete remission rates. In other words, the patients survive uh, induction despite that high white cell count, as long as you have good blood product support at the same time. In high risk patients, when you give idarubicin, you don't see that problem at all. The white cell count might be high to start, but typically falls pretty quickly with 4 doses of idarubicin, and gets down to virtually zero white cell count, as you would see with a standard chemotherapy induction for acute myeloid leukemia.
We really enjoy this too short meeting, but was for me was excellent. Is a biggest opportunity to share with a huge experience in this topic. So here, Don Mauricio is going to talk to present the next person to present this experience in IPL.
Thank you. Thank you very much.
Dr. Island, thank you very much, or as we would say here in Latin America, muchas gracias. We hope we have another opportunity in the future to receive your clinical research assessments that can always help us understand the scientific advancements worldwide. Now we will continue with the Peruvian APL case, but from here on, we will continue in Spanish.
Okay.
Ujú. Muchas gracias a todos. Y ahora vamos a un caso local de la región LATAM o latinoamericana, donde, como todos sabemos, vivimos unas realidades y unas limitaciones diferentes. Sin embargo, a medida que disponemos de espacios como este, logramos construir soluciones para beneficio de todos.